Good morning, everybody. We'll get started. Can everybody hear me okay? Great. So my name is Vikas Saini. I'm a lapsed clinical cardiologist, practiced for about 30-some years, private practice, also in academia, kicking around here in town at some of the Harvard hospitals. I've done teaching and research, and have a little bit of a business background, was co-founder of a medical device company that was successful, founder of a healthcare delivery company that was successful, and also founded an AI company that failed miserably, but that was 20 years ago, a little early. In any case, right now I am the president of the Lown Institute here in town, and the Lown Institute is a think tank that's dedicated to bringing bold ideas for a really just and caring system of health. That's what we believe. And I think it might at least help to share my prejudices as we get started. And they're really the following. It's our core belief that the American healthcare system, in the language of medicine, is suffering multi-organ failure. This is a patient that's really on or nearly on life support. And there are a lot of reasons for that, and I'm not going to enumerate them all. Some of you will know some of them. Certainly high prices, wildly varying quality, safety. There's a fair bit of administrative waste and a lot of what's known as clinical waste, or stuff that really doesn't change the outcome for lots of reasons. And we don't have time today to get into that. But it also, fragmentation. Some of you may know in the provider community, high rates of depression and burnout. So it's really not a pretty picture. And in many ways, the task that we have requires a full mobilization, almost a grand strategy for the whole country, and maybe even a grand coalition. Now, we're here today not to talk about that, but that's what I do and what I think about. And I think the only other point I would make to remind us all is that the United States is a bit of an anomaly in advanced countries. The whole employer-based system of financing and providing health care is a kind of historical accident in the sense that during the wage freeze of World War II, providing health care became a benny that did not change the wage structure, ostensibly. And ever since that got embedded, we have the system we have today. And so, for better or worse, whether you like it or not, employers and benefits managers are in the mix dealing with this healthcare system, which has lots of strengths and, as I said, a lot of weaknesses. So, most of what I'm interested in is going to be more at the national policy level. That's not why we're here today. Today we're talking a little bit more about what can employers do given this situation. And unlike national policy, where you have to deal with the entire country, the task here is to focus on the slice of the workforce that are your employees and try to figure out, what's the right path. So that's what we're going to talk about today. But first, let's introduce all our panel. So why don't we each introduce ourselves, starting with Wendy, and we'll just go along.
Hello, my name is Wendy Hultmark. I'm an HR director at Elsevier. I am based out of Cambridge here in Massachusetts, just across the river. Elsevier is a global information analytics company specializing in health and science information. Has a long legacy in publishing and is making a transformation into data and analytics.
Hi, I'm Natasha, Prasad, and I'm the Vice President of Customer Operations at Cleo. Just curious, quick show of hands, how many of you here are parents? Raise your hand if you're a parent. Okay, great. So Cleo is a digital health platform that delivers support to parents. So health, wellness, career-oriented support, all the way from preconception, pregnancy, postpartum, through to the fifth year of parenthood. I lead the global teams of practitioners who are supporting families directly, and then also lead our implementation and success teams. And we're based out in San Francisco. I actually spent 2 years in Boston at business school here, and so really great to be back in the city and looking forward to the conversation.
Perfect. Good morning, everyone. I'm Melissa Frieswick. I'm the Chief Revenue Officer at Maven. This has been the most amazing and fulfilling position that I've had in my entire career, which has been a really good one. We also work in the realm of working with individuals, families, partners, different communities that are looking to expand their families, and then also help drive diversity in the workforce. I'm going to just say, very quickly, first of all, we were founded 5 years ago, and it came out of, some of you may have actually met our founder, Kate Ryder. She's in the marketplace all the time on a global scale, talking and driving and initiating the conversation to say the system for healthcare, I think overall I agree with you, healthcare is broken. But no doubt, when you're expanding your family, my goodness, is it fragmented. And whether you're looking at issues in India or issues here in the US, I think the fundamental experience is we all, if you have gone through it, know that some part of it maybe didn't have quite the outcome you were looking for or was just more challenging than it needed to be. And so Kate, in her experience and in living in 5 different countries early in her career, I think made a lot of friends and saw friends go through this, and that was really the impetus of what came to be Maven. And we solve for it being really, really clinical because it's great to have engagement. We all want it. But we know, and especially sitting here in front of employers, we want outcomes. We want better maternal outcomes. We want less babies in the NICU. We want more moms breastfeeding if they want to. And to get that, you need clinical diligence, which I know we're going to talk about here today.
So why don't we talk about that in a minute?
Yeah.
David, introduce yourself.
Thank you. Hello. Well, I'm honored to be here with all of you on this great panel. My name is David Krieger. I'm with Gallagher Communications and Consulting. Gallagher is a 90-year-old company. We're located in out of Chicago, and is a proud winner for many years and the only consulting firm to win a Global Ethisphere Award for our work and our dedication to ethics and quality guidelines. My background, I am Canadian, working half-time in Canada and half-time in the United States. I have an office in Toronto, an office in Atlanta. My background is both on the benefits consulting side and on the communication side, having owned and operated a consulting firm for 26 years. Today's topic, the future of healthcare, is very obviously timely, and there's going to be hopefully, if you walk away today with a little nugget, it'll be time well spent.
Great, thank you. So I'm going to ask 2 questions, really. 2 questions. One on the sort of employee, patient, family side, and then one on the sort of providers, doctors, hospitals side. And that's it. And I will invite our panelists to not take my questions literally. As I said, this can be like jazz, and you can relate however you feel like relating to those questions. But I think that's an important way to get started. So in the clinical world, there's a constant tussle between managing the whole population or panel and managing the person in front of you. And I imagine in the coverage and benefits world, there's a similar challenge of sort of managing everybody with a one-size-fits-all package versus providing real differentiation. So, that's a bit of a challenge. And so my question really relates to that. As you try to tailor either different approaches or narrowcast different approaches, what trends are you seeing? And in particular, I'm very curious about, is there a difference generationally or culturally between people in their 20s, 30s, and 40s, people in their 50s and 60s? And the second way, at least in clinical medicine, we think about it, there's a vast number of people who are the worried well, and they need reassurance, they need a quick turnaround, they don't need the user interface of current healthcare, which sucks. But basically, That's one group, and then there's another group which is sort of more chronic, low-grade, functional. Maybe it's mental health, maybe it's, you know, low-grade sort of management of diabetes or a chronic condition. There are a lot of challenges in all of that. So that's kind of a big topic, but I thought that would be a good place to kick off. So what do you think, Wendy?
So I'll latch on to one of the earlier pieces that you made, and our organization, as I mentioned, it has a long legacy as a traditional publishing house. It actually has a history going back 150 years or so. But more and more, we are moving towards data and analytics as the services that we're providing. We're doing a lot with acquisitions. We're really investing in technology. And what that means from an employee standpoint is that we have a large population who have been with the company for a very long time and have more maybe traditional expectations around healthcare and other benefits, and yet we're growing in other directions that require us to look at the workforce of the future. We do a lot of acquisitions of small technology firms who have their own approach to healthcare and benefits, and so that's been a real challenge for us. The way we are dealing with that, so we've taken on board a lot of employee feedback. I think a few years ago we really aggressively went after the costs of healthcare. Moved to pretty much all high deductible plans. Really got away from internal service provided by the company for healthcare. And we're scaling that back a little. The feedback we're getting from people is that it's a bit too aggressive. And when we acquire companies that, small technology firms with tending to have a younger population, they're not impressed with that model. So where that has left us is, looking to think about how we're balancing those costs. I can't get too specific because we're going into open enrollment, but we are shifting how we invest. We're reinvesting some in medical, simplifying the portfolio of health coverage that we offer, and we're also complementing that with more paid leave. That's a big topic for people, and we're really, from what I've seen, we're really doubling down on that.
Great, thanks. Natasha?
Yeah, so 100% agree that there are a lot of challenges with the US healthcare system and also internationally, right? No one has nailed this. And one of the real gaps is around the transition into parenthood. That is just not supported well from a health perspective, from an overall mental health and wellness perspective, and from a logistical perspective. And one of the founding principles of Cleo is that the employer has a fundamental role to play. Most of us will be, or most people want to be parents at some point, and when that transition happens, most people will be employed by someone. One or both parents, if there are two, will have an employer. And so the employer is in a really strong position to be able to deliver on that health, wellness, emotional, and logistical support. And our approach has always been to combine the human aspect of the support, so the coaching, the guidance, a lot of which can be delivered really effectively outside of the pure clinical realm. So some of the adjacencies around coaching and guidance, which is clinical in nature but not necessarily medical in nature, and combining that with technology, with algorithms that can predict and see around the corner to say, the 4-month sleep regression is coming up, this is what to expect with your infant. Or pelvic floor therapy would be really appropriate at this point. And especially if you're a new parent, you just don't know these things. And so the healthcare system being very reactive doesn't provide that proactive, anticipatory guidance that can be really, really transformative in terms of the overall experience of a new parent, and also their experience in returning to work and transitioning back into the workplace with these two very, these almost competing identities, these competing demands on their time and their energy, and the support around that has really been lacking. And so that's, we found a lot of fantastic outcomes and a really great fit in approaching it with that combination of data and technology as well as the human touch.
Yeah.
Listen.
I very much agree with what Natasha just said, and as a working mom myself, I actually remember the first meeting I showed up for, and I had 2 different shoes on, but they were also different colors, and they were also different heels. One was high and one was flat. So if you've been through it, you know, like this, right, it resonates. Just to kind of take a different stroke at, and I guess change the conversation up a little bit, at the panel right before this one, there was an awesome speaker. And one of the things she said, which I found so powerful, is a lot of times we talk about diversity in our workforce. And we think about diversity as age and gender and generations, and all that is so true. But you also have to think about diversity in location, right? In economic status and work level, right? Where they stand in the organization. And to Natasha's point, when you transition into growing your family, maybe with the first child or maybe by growing it more, and then transitioning back to work, that experience is so unique to that individual. So when we work with, you know, an employee in India and we're talking about everything that comes with arranged marriages and how do we get you back into the workforce when it's culturally different, that's a different conversation than one that we're having here. And I'll give you a good example of that as well. A lot of times you work with people who are located maybe in the center of the country. They don't have access to all the great provider types that we do here in Boston, all right? So being able to put an endocrinologist in front of them through telemedicine that they don't have in their area, I think we have to be aware of things like that as well as we're addressing a lot of the gaps that you're referring to.
Thanks. David.
Well, I obviously agree. I think the whole issue of support and providing information to people's come up. You know, one of today's topic, you know, how employers can provide better health care is interesting. I do like to bring people back, though, to recognize that even with the existing health care that is being provided employees, there's a big gap in employee understanding of what's available. And that creates all kinds of issues for that individual in terms of getting the right kind of health care, clinical or other. But just basically from an employer perspective, providing all these benefits and not understanding. I have a little cheat sheet here because I didn't want to misquote statistics, but it seems that only 7% of consumers can correctly define the terms premium, deductible, coinsurance, and out-of-pocket maximum, according to the United Healthcare Research. Yet 50% aren't sure what they pay in healthcare costs each month. And 55% of employees estimate that they waste $750 per year out of ignorance and making bad choices. And that's certainly what research at Gallagher we can support. So we can't spend a lot of time because we have time, but I just think that as we talk about this, we have to keep in mind that providing you know, the challenges are going to be existing for some time. But you know, back to basics is how do we make sure people understand where they are, what their situation is, what their healthcare requirements are, ensure that enrollment is properly done so that people are making the right choices for themselves and their families.
Dialogue in that?
Yeah, please.
No.
It's against my nature, I have to. So it's kind of interesting. I remember when I worked for a health insurance company, right? We were struggling with that same thing, how to communicate. And it's interesting because when you look at trying to find actual impact and outcomes, you think about the fact, let's say with maternity, like some of us are dealing with, there's a natural, I think, belief. Of course, if you can identify high risk, right? That's where a lot of the claim savings are. But getting back to your question about the basics, we find when we first start interfacing or interacting with a member, one of your employees, most of the time, they actually don't even have an OBGYN. And we're only, you know, we're trying to get everyone we can in first trimester, but sometimes we engage people in second trimester and they don't have an OBGYN. It's such a fundamental, you would think, of course you get one when you're entering this stage, but it's the very basics. How could you even begin to look at high risk if they're not even going to a doctor just to understand what risk is or what normal looks like? So I think it's a fundamental issue, whether it's definitions in language or experience.
And the basics of, you know, everyone provides a benefit plan for all kinds of reasons, attraction, retention, but to the relationship between all those things, communication and employee engagement is really at the heart of this.
Great. So let me turn to that second question, and then we'll open it up for general discussion and questions from the audience. And that's on the provider side. So, you know, there has been a trend, and Wendy, you alluded to it, of creating high deductible plans. The theory of this case is that if employees have a little more skin in the game, There is a potential to do more shopping for services. The problem from my perspective is much of healthcare is really not very shoppable. And so I'm not surprised that, you know, you're having to, you know, react to the reactions of employees. But now you're sort of out of the frying pan into the fire, because once more we have a situation where if the deductibles are less and there's a lot more sort of engagement with the healthcare system, the sort of irrationalities in cost structure are going to come back and haunt everybody. So on the provider side, my question is this: are we, you know, if you're trying to provide the best possible care, do we have enough data analytics to, to get a sense of who the right folks are, who the right networks are? Or are we all opening up U.S. News and World Report, which is a beauty contest primarily? Do we have the data? And if we do have the data, and we're stepping back from high deductible plans, which means we're sort of sharing some of the financial risk, are we ready to start talking about narrow networks? Certainly Walmart is there. They're saying, you know, if you can't do X at this price, you're not in. So I'm just curious what your thoughts are on that question, and then we'll just open it up.
I mean, the way we think about the quality of our specialist network and our guide network at Cleo comprises of a few different things. So part of it certainly is expertise and credentialing, and that is a fundamental requirement of our process to choose to work with someone and add them to our network. But a lot of it is the humane and human aspect, so it's the experience as well. What is that person's essentially bedside manner? Are they going to be neutral when they advise you around breastfeeding, or will you feel judged? Will you feel reprimanded for not doing the quote-unquote right thing? And so that's something that we really bake into our process as well, from that perspective of the experience of the patient or of the customer, making sure that they have a relationship of trust and a personal deep connection with the person, so that they can really build from there and also reach out to that person if they have things come up down the line that they might not be able to find the right resource for as well.
And are you measuring that? Are you surveying for that? How are you getting that sense of trust?
Yeah, exactly. So we have an extensive interview process where we screen for a lot of these things, including essentially bedside manner, and then we have an ongoing process of feedback. So because we're an app and we're very data driven, we collect ongoing regular feedback at every single touch point. So whether you are messaging with an expert, whether you have a virtual consult with somebody, if you have just picked up the phone and spoken to someone, you provide feedback at every interaction. So very similar to whether you're taking an Uber or a Lyft and rating your driver as out of 5 stars, you have that cadence built into your interaction where you're providing regular feedback. If someone in our network receives more than one piece of negative feedback, we work on actually removing them from the network. So our kind of quality bar is very high, and we really listen to the user's experience, keeping that at the forefront.
So I can see, since you're building a provider network, you're really at the front line, and you have a capacity to do that. How about benefits managers who are very removed, and really, what's the dashboard? How do you even think about that? I know it's tough.
Yeah. I actually don't really feel like I'm well positioned to comment on that, just based on my own role with the company. Yeah.
Okay.
Well, I'll say, you know, I'm Canadian, so we don't have these things, but obviously I work here, so I'm very familiar. You know, I really think that, again, as we think about the future and how can you deliver better health care, obviously these topics are often in reaction to health situations, and I think the opportunity for employers is to look at wellness, to look at the individual, you know, physically, emotionally, mentally, and what can you do to help prevent, and what it does for your business as you're able to do those things. You know, what you find, of course, is reduced absenteeism, reduced disability, increased engagement, and that, of course, funnels to the bottom line. And prevention is a lot more less expensive than dealing it again. I think these things come back to communication, creating a climate and a culture of wellness, and that tends to be what drives, frankly, high-performance organizations.
I think fundamentally, providers want to do good, right? They're just put into this model where they have to push through so much volume and they don't necessarily have all the tools, and there's a lot in the system that works against them. We find we haven't done any recruitment since the first, I think it was 8 months, 5 years ago when we founded. Everyone who applies to our network is inbound, and it's because you give them purposeful, meaningful work in a situation where they can actually win with their members. The other thing is, I think you give them a seat at the table. So I'll give you an example. We have a very large network which does telemedicine with all of our members. Of that, in addition to medical directors that are on staff, we have a core group of 19, we would call them peer leaders, and so they're clinicians and people who are in our network, but they actually come on site on a regular basis and they help us build our product. So they're influencing, they're telling us what they struggle with. We had a session just about a month ago, and one of the pediatricians said the reason she does Maven at night is because she has a practice during the day, but at night, almost every appointment has both the husband and the wife, or two partners, or two spouses sitting together. So she's like, it's the only time I get to dialogue with the whole family. So she learns, and I think that's part of it, is giving them meaningful work and access. And then the second thing is change up the payment model. And I would say to employers, demand this. At Maven, we don't, it's unlimited use of the network. And as an employer, you pay one fee. The reason that's important is employees like high deductible health plans, they may get choice if they can find it, but they still have to pay out of pocket, and that's a barrier, right? Right, wrong, or indifferent. But when you change up the model and you make it so it's unlimited and you can throw that out there, that feels better to the employer and it feels better to the employee. So I think put pressure on the pricing models.
Great. Let's open it up. Anybody in the audience have any specific questions or anything they want to dispute or debate?
I don't have anything to dispute, but I'm trying to listen to your comments relative to the idea of provide better health care. So what exactly are we talking about that is better? So maybe what I'm trying to listen to is what kind of design framework, if I'm designing a healthcare plan, what is that design framework that I should be thinking about? Is it about the type of services? Is that about, catering to certain age groups, global regions, because different countries have different laws, size, or with an intention of really differentiates ourselves?
Sure.
It's not me. Differentiating my company with other company. But I'm not able to quite hear what is the contemporary design framework that we should be thinking about to make things, as you call it, better.
I'd love to speak to that. At Cleo, some of the dimensions that we think about, and I think many people would share this point of view, is thinking about cost, quality, and compassion, right? So what's the actual dollar cost to providing support, achieving the same level of quality outcomes, and having a positive experience for the recipient or the patient on the other side of it. So to start with quality, we think about that not just in terms of outcomes, and we are very outcome driven around things like breastfeeding, baby in the NICU, gestational diabetes, high risk pregnancy, et cetera, things like that. But also what is the quality of the support they're getting from a human perspective, and how proactive is that? So oftentimes in our healthcare system, if the support that is being sought out, it's often too late to truly address preemptively the issue if you've had to self-identify, right? So if we're able to use our combination of the trusted relationship, the longevity with a Cleo guide, along with the data and predictive analytics that we have to anticipate the need and preemptively solve for it, then that's going to increase the quality and also reduce the cost. And then additionally with quality, a lot of it is the cultural nuances, and Melissa, you referred to this as well. I mean, I personally grew up in India and the UK. My daughter was born in Australia. It's very different by region, not just internationally, but also within the US, right? And so finding a provider who is culturally appropriate, who is well-versed in the nuances of your societal structure, of your clinical support network, is really, really important to the quality of the experience. And lastly, the compassion piece. I won't touch on that too much because I already spoke about that. But like I said, a lot of it is the emotional side and the mental side of feeling really supported and having that trusted relationship as well, where you can hear the advice, you can internalize it, and you can act on it because you have that trust with your provider.
Well, I think the question was, you know, if I'm starting from scratch, what do I do? How do I build this? And I absolutely agree with Melissa, but I think that if I were started from scratch, I would do that. And I find many organizations today, you're running along, you've got your benefit plan, you're making changes, there's all kinds of new products and services coming at you, and your kind of head is spinning, and what do I do? And really, I think the answer is benefits are, first of all, they're money. It's money. It's just money. And you can call it life insurance or health. It's a bucket of money. And the question you have to ask yourself is, as an organization, what are my benefit plan objectives? And how are they aligned with my HR strategies and clearly our business strategies? But then how do you spend that bucket? And it's important to try to understand, and you know, certainly your culture is a factor in that. Are you paternalistic or are you maternalistic? What are your expectations and what action are you trying to get your employees to behave, and how can these plans help support that behavior? And so I'm a big believer in kind of sometimes taking a step backwards, looking at those objectives, and if you all don't have objectives, then that's, you know, next quarter's project because you have nothing else to do. You have a very complex job, but I think that's where I'd start.
So I'm going to take a step back from Maven and just kind of address directly, as you did, what I think the fundamental challenge is trying to find the solution that is specific for you is likely very different than most people in the room, right? Everybody has a slightly different edge within their population. So I would say start with your own data. Understand where your claims are, understand the cultural differences. Are you spread across multiple locations? Are you all in one location? That impacts everything from how you design the program to how you communicate it. So data is always where I start. I was an underwriter earlier in my career, so that might be a little biased, but that's kind of where I would start, is with the culture and the data. I think from there it's about procuring the right partners. There are times that point solutions are great. There's a place for a lot of them. Sometimes there's times that, like what we're trying to fit in Maven, where you think it's a whole area of a type of delivery that can't be broken, and so it's all in one, and that goes with one vendor. But you have to make the vendors talk with one another, because that leads to the third one, which is ease of use for your population. So is it accessible? Is it realistically that they can engage with it? If you have a culture where it's really hard to leave during the workday, telemedicine makes sense. If you have a population with 24-hour work shifts, you've got to find things that are not just in person, right, for them. So I think access, and to your point earlier, communication. The way you communicate a program will look different organization by organization. So I guess, data, finding the right vendor partners, and then ease of use, including communications, would be my recommendation.
I align to David's comments, where I think the decisions become a little bit more simple when you start with your strategic objectives for the business and for your people, and that broad pot of money, as you put it, and how you want to be able to invest that based on the future needs of your organization, which will become the present needs very quickly. So starting from that position, and then you can do the deep dive, and I completely agree with the points that Melissa and Natasha are making around how to think about the healthcare challenge in particular within that. But without that compass of that broader perspective and the strategic direction of your organization, it's such a complex topic that, as you said, it can be very difficult to know where to start or how to prioritize those decisions.
And Wendy, that's a great point. I think our bias is health because we're so in it. But right, a total design, total rewards means so much more than just employee benefits, right? Or health perspective, right? It can be time out of the office and flex work schedules and things like that as well.
So I have a question which relates to the comment that, and I don't want to put words in your mouth, that effectively your employees, if they're using, Maven or Cleo, that they're able to access and there's no real clock running, or it's not volume driven at all, it's driven by need. If that's true, from the business point of view, from the money point of view, is that because you've got salaries for your providers? Is that because there is no volume component in their compensation? And if that's true, then you're creating a very different culture, and maybe that's part of the issue. In the rest of the healthcare system, there's a constant tension between, half your salary is coming from a volume-driven model and half is coming maybe from contracts and risk, and it's really a schizophrenic existence, and quite often neither is done well. So I'm curious what you think about that.
That's a great question, and something I spend a lot of time thinking about leading our practitioner operations. We have two components. So one component, which is the guide component, and you're assigned a practitioner who is an employee of Cleo, and so they are salaried. That person is available to support you essentially 24/7. And that is not session-based, it's not time-boxed, it is fluid, it's interactive and continuous essentially. So you're messaging with this person, you're picking up the phone and calling them, you're emailing them, etc. And then we also have our specialist network, which is more, quote-unquote traditional in terms of being volume-based. But what we found is that those two components, combined with the technology, the content, the videos, the workshops, the forums, the parent-to-parent support, overall works out very much in the favor of the employer in terms of cost and support versus accessing, the traditional system and the lack of many of those things in there as well.
Yeah.
Great, thanks.
So fundamentally, I agree. And I think a lot of companies, a lot of the coaching companies out there right now, even if you just step into the well-being space, they have, we all agree, I think fundamentally, having one person that guides you through the experience, end to end from a member perspective is a good model because they stay with you through every stage. Having the clinicians or the practitioners in a separate network, I think it's really important. The thing to be cautious about is, what is the goal you're trying to achieve, right? We don't want to get in the way of in-person care. There are times you need in-person care, and I'll give you an example with maternal mental health, right? Postpartum depression. That is an area where not all moms break down in the business hours when someone is sitting in their office, right, their practitioner office. And so you have to have access outside of those hours, but you don't want to get in the way of the in-person, because when someone's really struggling, the immediate here and now on-demand access, that's how you take care of the person and you prevent the catastrophic. It's also how you steer them into that either in-person or inpatient that they need for the ongoing care. So I think it's important to also just differentiate that you have to have a wide variety, right? We have over 20 different practitioners in our network because we acknowledge there's so many different types of care needed, but then also don't overlap with existing networks. That's what your health plans are there for, but we've got to get people just to the right period of care at the right time, and that's really important.
We're almost out of time. Any last words, David?
Well, I was going with the last word. I think I find this topic very interesting, how employers can provide better health care. And I'd argue, well, it's not your job to provide better health care. It's your job to provide a framework. It's your job to make employees understand what your commitment to this benefits deal is. And it's your job to make sure they understand and can make informed, educated decisions. And if you do that well, I can guarantee you will have a return on your investment in numerous forms. And that every dollar you spend doing those things will be money back to you. And I think that's how you can really help your organizations and your employees in the most effective way.
Great. Well, with that, we're out of time, so I want to thank our panelists and thank the organizers for having us.